And welcome back. It is Breast Cancer Awareness Month, and the folks at RadNet and Breastlink want you to be aware of what's going on in the community. I want to welcome Dr. Valentine Bonev to the program. Thank you for joining us.
Thank you for having me.
Let's talk a little bit about how we get an assessment in the first place. If a woman feels like there might be something off, they're feeling a lump, is that the first place to start, or should we be starting with mammograms even if we don't think anything's wrong at a certain age?
So national guidelines recommend mammograms once a year starting at 40 years old for women who are average risk. If someone's considered high risk, such as they have a family history of breast cancer, they may start getting mammograms earlier, such as in their 30s. If a woman notes a change in their breast, like a lump, skin changes, a rash, nipple discharge, nipple inversion, we want them to go to their doctor immediately to be evaluated. The standard of care, though, is a mammogram once a year and then a breast exam once a year. So it's important that you do both because no one exam is perfect.
If there is a family history, then it should start a little earlier. Are there also genetic tests that you can take to see if you are carrying that genetic marker with you?
Correct. So we do offer genetic testing to patients who, let's say, have a family history and maybe their mom, their sister, their aunts, their grandmother of breast cancer or other cancers such as ovarian cancer. So what genetic testing entails is it's a blood draw or it's a saliva swab if you're not very good with blood draws. And we're testing for gene mutations that may have been passed down from your parents. And if you do test positive for a gene mutation, we know, depending on that gene, what cancer it may be associated with. So for example, you may have heard BRCA.
Right.
There are two BRCA genes. Both of them are associated with breast cancer. So we know patients who test positive for a mutation in that gene have a very high risk of breast cancer in their lifetime. So at least 60% risk of developing breast cancer.
Higher than the average.
Exactly, versus 12% for the average population. So we know that it does not mean that just because you have a gene mutation, you will 100% get that cancer, but it means that you are very high risk and that we will monitor you more closely. So it may not only just be mammograms and breast exams, it could be ultrasound, it could also be breast MRI. So it's just very important to be evaluated by your physician. Hey, do I qualify for genetic testing? Should I get it? And then talk about the potential impacts of genetic testing for that patient.
So that information is just kind of something that people can value and they'll know, and they'll have that in there in terms of how they monitor themselves and how they get their care, right?
Correct. So it's bringing awareness. So awareness is power, and that's one of Breastlink's motto, especially for Breast Cancer Awareness Month this October. So if we are aware that you're high risk because you, let's say, have a family history or you have a gene mutation associated with breast cancer, we're going to observe you more closely.
Now, are there genetic tests that go on? Do we do that multiple times, or does the one test really kind of cover everything?
So what I offer is a comprehensive panel, which is around 71 genes tested for not only breast cancer, but ovarian cancer, pancreatic cancer, colorectal cancer, et cetera, because there's a lot of overlap with the different cancers with each other. And if you get a comprehensive panel, usually you just need one test. I've had patients who've undergone genetic testing decades ago, like maybe 10 plus years ago, and at the time, testing was very limited. So they were only tested, for example, for only two genes, BRCA1 and BRCA2. They tested negative. Now we know that there are other genes in addition to BRCA associated with breast cancer. So now when they do testing, now we do the expanded panel, and some of those patients who tested negative for BRCA actually test positive for another gene mutation that we now know of. So it's important, even if you've had testing, bring those results from the past to your physician and see, do you need to have updated expanded panel testing?
When folks get screened and they get that news that, hey, it's breast cancer, and after the test, those comes in, what is it like for someone to come into that world? It's a scary experience. There's all sorts of BRCA and all sorts of things that they're hearing for the first time. How do you as a physician not only deal with the cancer, but also the patient?
That's a great question. So a lot of the times I'm breaking the news to patients, which is like dropping a bomb on them. And I tell them, I'm gonna give you a big overview of your diagnosis and your treatment. I know it's a lot of information, but I just want you to know that this is not life-threatening, and you're gonna have a full team behind you. So at Breastlink, they're not only working with me, the surgeon, they're gonna see a medical oncologist who I'm gonna refer them to, a radiation oncologist, physical therapist for their recovery after surgery, a plastic surgeon if they're interested in reconstruction. And then we also have Breastlink Angels, which is unique to our practice. So these are former patients who've actually had breast cancer, and we link them up with our current patients who have breast cancer. So maybe I have a young mom in her 30s with 3 small kids. We're gonna link her up with a Breastlink Angel who was in that similar situation, because they're going to be going through different experiences versus someone who's, let's say, 70 years old with a early stage breast cancer, right? So there is a lot of course, anxiety going into it. It's very overwhelming. And so what my job is to provide them not only the clinical support, but emotional support, and let them know that I'm calm. I'm gonna let me worry about everything. I don't want you to worry. I need you to be in a great mental state and a great physical state so you can get through your treatment successfully.
And there's a difference between, like you said, a 30-year-old young woman who is diagnosed than a 70, or the treatment plans are going to be different, right?
Yes.
The aggressiveness of the cancer might be different.
Yes.
How does the entire, like your cancer panel come together with the oncologist, you and others, and come together and make that team approach? From what treatment do we start first? Do we do surgery? Do we do chemo? Do we do radiation? How does that kind of come together?
So it's a multidisciplinary approach where we're all actively communicating with the other physicians and with the patient as well. So we discuss the patient's case, and for example, a young 30-year-old is more likely going to have an aggressive breast cancer. So we're probably going to initiate aggressive treatment, which could include chemotherapy first, followed by surgery. She may need radiation therapy. We discuss that timing as a team, then we bring it to the patient and say, hey, this is what we talked about your case, this is what we recommend, and this is why we recommend it. What, do you feel comfortable with that plan? If the patient does, great, we'll initiate treatment. If they're not, then we bring it back to the team and say, the patient's very apprehensive about chemotherapy because these are her concerns. Let's go ahead and address that. Because, for example, with chemotherapy, patients are very scared about it. Patients are also nervous going into surgery. It's very understandable. A lot of my patients, they've never had surgery before in their life, and now they have not only a breast cancer diagnosis, and then they have to undergo general anesthesia for surgery. So we're just all there to support the patient, but it's very key for us as physicians to communicate with each other, and then to communicate with the patient, and then to listen to their concerns. So why are they, let's say, against treatment? For example, some patients are like, I don't want to do radiation. Okay, why not? You know what? I don't want to do it because it's too far away from my house. It's an inconvenience. Okay, then let's find something closer to you, because the ultimate goal is to treat the patient so they never have to deal with this again.
Now, has chemo evolved over the years in terms of, like, are there more kind of biomarkers that you can tailor and make a chemo to now that where the side effects aren't as great anymore?
So chemo has definitely evolved, and honestly, the whole breast cancer treatment field has evolved to be more individualized. If when you came in, let's say 10, 20 years ago, pretty much every patient with a breast cancer diagnosis got chemotherapy, then they had a very extensive surgery where usually the entire breast was removed, and then a lot of lymph nodes were also removed. So this is a more morbid procedure with longer recovery. And then a lot of patients got probably additional chemotherapy and even radiation therapy. Now we know that patients don't need all of that therapy. In some ways, it can actually be more harmful to them. So we can tailor it based on the biological markers, and we can tell how aggressive a tumor is. So we don't have to offer such aggressive treatment to every single patient. Now with widespread screening mammography and patients being aware of what to look for, a lot of patients are presenting very early. So with very small cancers, meaning they don't need to undergo chemotherapy. They can have a lumpectomy, which is just removing a small part of the breast. They may or may not need radiation therapy, especially if they're 70 plus years old.
I was going to say, for the older generation that watches this program here, the treatment plan has changed drastically in terms of, hey, we're not going to do the breast removal, we're just going to maybe do a lumpectomy, right?
Correct. So women who come in who are 70 plus years old with a breast cancer diagnosis are usually diagnosed with a small breast cancer that's considered less aggressive and hormone receptor positive, so expressing estrogen and progesterone receptor. If that's the case, they can undergo a lumpectomy. They probably won't need radiation, and they won't need chemotherapy. So the only other thing in addition to surgery will probably be recommended is something called endocrine therapy, which is targeting those positive receptors, and that just lowers the risk of that cancer coming back or a new cancer coming back in the future. So the point is, just because you're diagnosed doesn't mean you're gonna have to undergo such extensive treatment. Patients do really well with treatment, even if they're in their 70s, because we've now tailored it down and have really made it as least invasive, but with maximum treatment impact as possible.
All right, that is Breast Cancer Awareness Month. If you take away any message, make sure you get your screening done and make sure you see your physician. Dr. Valentina Bonev, thank you so much for joining us from RadNet.
Thank you for having me.
You're watching This Day. We'll be right back.